Hi. Thank you for joining us.
Thank you for the kind invitation. It's an honor to participate at this joint meeting.
Okay, then please begin your presentation.
Yes. Okay. Can everybody see this?
Yes, we can see it.
Okay. Good morning. My name is Mirza Pojskic. I'm a neurosurgeon from University Hospital Marburg, Germany. And I'm going to have actually two talks in one today on robotics in spine surgery and on application of augmented reality for spine surgery. I work at University Hospital Marburg in Germany. Our professor in German is Professor Pojskic, and we are a fairly known department for implementation of novel technologies in neurosurgery. For example, our professor was head of the first intraoperative MRI in Europe in the 90s, and we are actually implementing every new technology which comes at the market in our own department. So robotics in neurosurgery has a very broad application, and today I will talk on robotics in spine surgery. So I think this slide depicts what we think that robots are and what is the imagination and what is the reality. Sometimes we imagine robots as androids who are going to take us out of the big picture, but actually one of the most developed robots there is Mars Rover 1, which is actually just a navigated car with a camera. So there is a very long way to go, and there is a lot of room for innovations in the technology of robotics in neurosurgery. So surgical robot would be any programmable power manipulator with artificial sensing that can assist in a variety of surgical tasks. And the first application was in the neurosurgical field used for brain biopsies in the 1980s. This is the so-called Puma robot. And the modern robots actually have a very similar design. So the idea of the design of robots with robotic arms has not changed a lot, but the design is a bit different, but the idea behind the design is pretty much the same. So we can classify them as passive robots and semi-active devices and active devices, and we differentiate further autonomous or supervisory controlled robots and teleoperated systems. So supervisory controlled robotic system is something which we can find in stereotactic brain surgery, where the surgeon plans the surgery offline on computer, downloads the plan to the robot, which executes then the downloaded plan while surgeon observes or supervises the robot operation. There is a telesurgical system where surgeon controls the robot in real time, and there is a shared control system, and actually the robots which we use in spine surgery are usually shared control systems, where robot and surgeon remain jointly in control of the procedure while the robot provides steady hand manipulation of the instrument. The thing is, we don't have a real robot surgery in neurosurgery. This is mostly cobot surgery, where cobot or robot assists with a distinct but critical and sometimes very difficult task of the operation. Step of anatomical localization, stabilization of the surgeon's hand during the prolonged microsurgical work, or targeting of a pedicle screw. For design, it is important to have a good compromise between size and strength and the stress the tool is under. We differentiate rigid tools, which are most common in spine and endoscopic surgery, and curved tools, which are used for transnasal approaches, biopsies, endoscopic craniotomies to minimize invasiveness and reduce recovery time. In the focus of research is actually now improvement on human-robot interactions, and the most important improvements are for force sensing and proprioception feedback, so that we feel what the robot is doing and the robot feels what we want to do. That would be a simplification of research field, which is now based on transfer of our proprioception to robotic arms, strain gauges, and optical force measurements. So robotics in spine surgery now is currently used only for assisted pedicle screw placement, i.e. placement of care wires. We know from the literature the screw misplacement can occur up to 8.7% of the time and can lead up to 1/5 of all patients to severe neurological deficits. That's why it is very important to put a correct and biomechanically stable pedicle screw without injuring any neurovascular structures. First robot for spine surgeries was Mazor, Spine Assist or Renaissance Israeli robot from year 2004. And since then, there has been a tremendous development so that we now have more than dozens of robots on the market, so that the price of the robots is falling and it is becoming more and more accessible to all parts of the world. So when we look at this recent review article, when we compare robotic surgery to navigated screws, CT navigation has the highest pedicle screw accuracy rates, but robotic-assisted surgery shows fewer breaches in the thoracic spine compared with freehand and compared with navigation. And this is actually the best application for the robotic surgery at the moment. This is one small overview of robotic systems: Mazor, X, Spine Assist, Renaissance, Rosa, Circ, Da Vinci, Nuvasive Pulse, Excelsius, and new robots which come from China and from South Korea, Tinabot, Orthobot, and Curexo or Curie Spine. So currently we can use them only for assisted pedicle screw placement or placement of K-wires. And pros are reduction of operative time, reduction of wound surface and wound healing deficit, high pedicle screw placement accuracy, 98.3% in robotic surgery versus 93.6% in freehand and 95% in navigation, decrease in revision and complication rates, and it is applicable with ORM and ICT. Whereas the time which we need for pedicle screw implantation is shorter, we need a longer operative time due to installation issues. We have registration and installation issues as an important con, and the learning curve shows usually no improvement of surgical efficiency. That means the robot needs its time for you to put a correct pedicle screw, robot assisted, and there is no really a good learning curve over time. You always need more or less the same time for that. So this article for 2017, this is 5 or 6 years ago, has shown 9 misplaced screws in 7 patients with a screw accuracy of 96.7%. This was with Rosa Spine Assist. And when we compare complication and revision rates in minimally invasive robotic guided surgery versus fluoroscopic guided spine infusions, we have that the Mazor robotic guidance has significantly lower risk of surgical complication and lower risk of revision surgery with a similar surgical time. And in single surgery series, there is no difference in the rate of clinically acceptable screws, in infection rate, in intraoperative blood loss, and in operative time, but there was a significant effect on precision and accuracy in Gertzbein-Robbins A screw placement. So GRS scale is actually still a standard, although this is a scale from the year 1990, with which we assess the accuracy of placement of pedicle screws, and A screws and B screws are actually that's what we are looking for in the robotic guided surgery. Robot time for screw is similar between different cohorts when you compare operative time in open versus percutaneous group. And the screw time or time which you need to put a K-wire goes somewhere between 2 and 6 minutes. In our personal results in first surgery, we had around 8 minutes, and then in the later surgery, it has fallen to 4 minutes, and I think in the last surgeries, in the last 10 robotic surgery which was done, it is now around 3 minutes. So you have a 3 minutes for one screw, which is perfect and which does not need to be revised ever again. We now have an age of active robots for pedicle screw placement. Active robot would mean that the head of the robot, the so-called kinematic unit, aligns automatically according to the pre-planned trajectory of the screw, and you don't have to bring the robot by yourself in the position or aligned to the screw trajectory. The robot does it by itself. All you need to do is to place it over the projection of the pre-planned entry point. I will show the video, which I hope will work, which will show what is the principle on how these robots work. So these were our results from last year, with mean time per screw of 8 minutes, 8.5 minutes, whereas we had in first 7 surgeries extremely long time. This is the time when you learn how to use the robot of 60 minutes, and the later surgeries up to 4 minutes, which is actually in concordance with the current literature. One of the quality measures of implantation of pedicle screws is to measure entry point, screw tip, and angular deviation of your actual screw to the pre-planned screw. And if the entry point deviation is under 2 millimeter, then you're off to go, and you will probably have a pedicle screw as you need it. So this is the robot which we use. It's called Circ from the company Brainwave. This is our intraoperative setting with intraoperative CT. Our steps when we perform the robotic-guided pedicle screw placement is that we have preoperative imaging. We plan the screws according to imaging. We do the intraoperative imaging with automatic registration. We fuse the preoperative and intraoperative imaging with a review of screws. And, excuse me, and then a review of pre-planned screw trajectories. We do robotic-assisted insertion of K-wires, and then fluoroscopy-assisted insertion of pedicle screws. We now don't use fluoroscopy at all, but we navigate the screw, and we put the navigated screw over the robotic planned K-wire. So this would be our operative setting. In percutaneous cases, we usually do a small skin incision to place a reference array, and then in that reference array, we try to place, we do the navigation. So in this video, I will try to show how, what is actually the principle, when and how does the implantation of the robotic screw is working. So this was one case. It was a pathological fracture. Excuse me. I have some difficulties putting the video on, so I suggest when I'm done with the presentation, I will put the video separately so I can show the technique. This is one of the cases which we've done. This is the intraoperative screenshots which show the instrument tracking with the robot, and this is the intraoperative CT which shows the correct placement of the pedicle screws. And even with the best of technology which we have, you still have cases like this where you put a very wrong or screw E, and the reason for this screw misplacement in this case was probably the movement of the reference array. So robotic surgery is actually there only to assist, but you cannot turn your brains off or brains out and hope that the robot will do everything for you. So you need to be very careful and try to check the navigation accuracy all along or during the whole time of the process. So what we now do, we do robotic-assisted K-wire placement and insertion of navigated pedicle screws. And this is one of the cases which we've done 2 weeks ago. You see the pre-planned screw trajectories, and then you see the actual navigated screw, which goes perfectly according to the pre-planned screw trajectory. And this is the way, especially in cases when you have very small thoracic pedicles, a very good way to put a biomechanically and safe screw, which you never have to revise again. So several manuscripts have shown that robotic assistance allows for placement of screws with greater screw diameter and length compared with surgical navigation alone, although with similarly high accuracy. There are also some people who try to put cervical pedicle screws, which in my opinion is not safe with the current robotic systems. Less fastened joint violations have been shown with robotic-guided spine surgery, and what robots are not able to do is to decompress, decorticate, or contour and place rod. But there are, however, papers which show that you can access a cabin triangle, put a cage, do an iliac fixation, metastatic cancer, or sacroiliacal fusion, also using the robot. There are also combination systems of two-dimensional fluoroscopy-guided robot-assisted percutaneous endoscopic transforaminal discectomy. So all the different technologies which we are talking about can also be combined. And future of robotics would be development of robotic suits, which we now already have. Safer and more tailored decompression, and what we hope is that one day we will have a robot which can do laminectomy and simple automated procedures with the so-called no-fly zones, so that the robot is capable of performing a laminectomy or a sterotomy, but that he can sense where the dura is to important neurovascular structures, which he then leaves alone. Gloves with motion sensors and automatization of simple procedures such as wound closure are several further application areas of this technique. I'm going to talk furthermore on augmented reality. There is also augmented reality assisted placement of medical screws, which can also be combined with robotics. And this large meta-analysis with over 20,000 screws has actually shown that robotic assisted instrumentation is far better, but that augmented reality assisted implantation of pedicle screw is associated with decreased radiation exposure compared with robotic instrumentation and fluoroscopy guided techniques. Future is now. 5G remote brain surgery performed in China first time in 2019, implantation of electrodes for deep brain stimulation, and also the first robotic spinal surgery based on 5G network for 12 cases also performed in China. So this would be one of the future advances where a surgeon in a very distant and remote part of the world can perform surgeries in another part of the world over 3,000, 5,000, 10,000 kilometers away using the 5G network. And this is a very interesting paper which has shown that in the control room, you can plan the trajectories. The robot can, according to a plan, go onto the planned trajectory, and the surgeons in the OR can then do the execution of the surgical plan. So will robots replace surgeon? In January this year, there was a full laparoscopic surgery without human help. And one would say never bet against innovation or technology. These are some media signs which show that the robotics is highly on its way, but also never bet against the human nature. This is just a small excerpt. What you can read in the non-scientific journal in popular media and in press, that robotic surgery is involved in 144, that's in 14 years. So I think, like with every technology, we will have a lot of resistance, and there will be decades until we implement this technology the way we want, because I think we will have a phase where we will rely on it too much, which will then be shown not as very good, and in the end, it will remain an aiding tool. But I don't think personally that it is ever going to replace us. So that would be robotic surgery. I'm going now to talk shortly on augmented reality in spine surgery. This is just a small selection of papers which we wrote in our clinic in the past years on microscope-based augmented reality, which we used. We combine it actually with reference array, which are attached to the modern operating microscope with integrated head-up displays in conjunction with navigation systems, which allows for augmented reality visualization of three-dimensional color objects in real time. We check the calibration by centering the microscope above the central pivot, and you can have various 3D objects visualized using the IR display semi-transparent, solid, or outline mode. And what is it? It's a significant advance which provides a real-time updated 3D virtual model of anatomical details which are overlaid on the real surgical field. And our operative setting is shown here. So we have the navigation camera, which looks at the same time at the reference area, which is attached to the patient, either to the spinal process or to the pelvis, or just taped to the patient. And the camera sees the reference area and the reference area on the operating microscope. And in that way, the software can track the intraoperative situation and provide you through the microscope 3D reconstruction of all the structures of interest superimposed in your microscope image. So we've published a series on lateral approaches for the on use of augmented reality in CT for lateral approaches to the spine. Very important is to have the correct navigation, because if you don't have the correct navigation, then the augmented reality will also not be correct. You can check the navigation accuracy in many ways with pointer. This is one of the cases with herniated thoracic disc, which was operated via a lateral approach. And you see here very nicely the contours of the vertebrae, the contour of the herniated disc. And this allows you for a very good intraoperative navigation and orientation if you want to operate on this complex surgery. The software is also capable of providing you a very safe area of osteotomy to perform for navigated osteotomies. It is also capable of reconstructing the implant which you have implanted in the control scans. So at every moment you have the real-time intraoperative updated information on your surgical field. There is a second video which I will also show at the end of the presentation. And this is the case which we've done just recently. 2 weeks ago, this is also a very large herniated disc. Calcified herniated disc. Nowadays, we know that the best surgical treatment for this herniated disc is to perform a navigated osteotomy via one lateral approach. This is exactly what we have done. You see here on the left side the intraoperative image with the retractor, which goes retroplurally on the spine. This is the check of the navigation accuracy on the central divot. And here you see outline of the vertebrae in yellow and also outline of the spinal cord in blue and outline of the herniated disc in yellow. And this is following the surgery. You now see the exposed spinal cord or exposed dural sac. And you see that the herniated disc is completely depicted and it is also completely gone. And there where the herniated disc was, you see the superimposed three-dimensional image of a herniated disc before the surgery. So it allows you really a very good three-dimensional orientation and understanding of anatomy. And you also see here that the dural sac has expanded over the amount of the resected herniated disc, which actually shows that the decompression is full. And this is also confirmed in our intraoperative CT. You see on the left side preoperative image and on the right side postoperative image, we have drilled out the posterior third of the vertebrae and the herniated disc completely. The patient recovered very well. She had a paraparesis. She has now no deficits and she's waiting for her rehabilitation. You can use augmented reality in spine surgery for navigated corpectomies, which is actually very important if you have a bad tumor or you don't want to injure the vertebral artery, which you never want to do, and you can do the very nice reconstructions and navigate yourself throughout the osteotomies. You can use it for posterior approaches, for reconstruction, and for surgical and access planning, approach planning, especially in patients who have several reoperations. And of course, for the intradural tumor surgery. For intradural tumor surgery, to have an intraoperative update with intraoperative ultrasound is also important because here we have problem that when you open up the dura, you have a CSF leak, and that CSF leak leads to shift of all the structures. It is very good for resection of cavernous malformations and other vascular malformations of the spinal cord because it allows you to reconstruct all vessels of interest and to let you know in any part, in any moment of the surgery, where are you, where is the tumor, where are the vessels which you don't want to injure. This is one case with a very complex hemangioblastoma and cranial-cervical junction, which was totally operated. You see here a very nice reconstruction of all the vessels of interest and its anatomical relations to the tumor. You can also reconstruct out of the preoperative image the reconstruction of the pedicle screw. You can also see when you do a surgery from behind or from lateral approach or ventral approach where your screws are, which is important if you do any kind of osteotomies and don't want to violate the screw which you have implanted before. We use microscope-based augmented reality. You can use also IR system with a wireless headset with transparent rear eye display, which projects intraoperative image directly into the surgeon's retina. And this would be one of the cases. I think this is a very nice depiction of how one head-up display works. You put a reference array on the patient somewhere in the pelvis, and you have the reconstruction. That's what we see on the picture down, and on the right side is actually how you see the anatomy of the spine and of the pedicle screw full head-up display. We don't use it in our department, we use robotics, but this is actually also a very good application of augmented reality, although as shown before, robotics would be in our opinion of the current meta-analysis, actually better. There are also papers to improve surgical workflow, minimally invasive transforaminal lumbar interbody fusion. A very recent paper published just in 2022 in the Neurospine. And when you look at the topic trends from 2012 to 2021 in area of augmented reality, you see that the spine is actually the hot topic. Augmented reality in spine is now the hot topic for research in augmented reality. So some final thoughts, it's very important if you want to use augmented reality, which is very helpful in challenging anatomical cases, to have a good navigation accuracy. This is best to be achieved with automatic registration, with intraoperative imaging, to do re-registration during the procedure, with immediate intraoperative quality control and objective evaluation of the intraoperative situation. It increases comfort for the surgeon in reoperation. It is a good tool for resident education. It helps you to estimate tumor extent even when registration accuracy is compromised, because you have also always a three-dimensional reconstruction of the tumor with its actual size. And even if the reference area is moved and the navigation is not 100% correct, you always have a feeling how big the tumor is and how much of the tumor you still need to remove. Shifting of the spinal cord occurs when it is decompressed, so it's important to integrate intraoperative 3D ultrasound, which allows an updated navigation. And since we implement all those protocols with intraoperative CT, repeated scanning can be performed with reasonable radiation exposure. And this radiation exposure for CT scan is actually on one X-ray of the lung. So it is a lot better for the patient than when you do it fluoroscopy. This is the department where we work in Philipps University in Marburg in Germany, written in the wood. I invite you all to visit us. These are some pictures of the wonderful medieval city of Marburg, where I live now for 10 years. I serve together with Professor Rumsky and Ms. Dr. Bob as a special issue editor of Medicina for clinical applications of modern technologies, neurosurgery and spine surgery, and I invite you all to publish your papers at our special issue related to implementation of modern technologies. I would like to invite also everyone to be a part of our second Bosnia-Herzegovina-Turkey spine meeting in beautiful city of Sarajevo in May 27 and 28 next year. It will be a joint Bosnia-Turkey meeting, but it will have an international faculty, and anybody who can come, who is able to come can join. I think city of Sarajevo is not unknown in China, and all people from China, when I met and said Sarajevo, they all knew where it was and what it is, which is actually a big honor for the capital of my home country. I come actually from Bosnia, but since 10 years I live and work in Germany. I also invite you to read our book from our research group on spinal cord tumors, which occurred in Mandarin last year. And I visited China in 2019 and had a very nice time there with my father, and I hope to visit China again as soon as it is possible for congresses and for other research and scientific exchange. Thank you very much. That would be all from me. If we still have time, I would like to show shortly 2 videos which I prepared, which I cannot put in my presentation. If we have time, if no, then it's also okay. Thank you.
I think okay. You would like to show your video of the
yes, I would like to show very shortly 2 videos just to get an impression how the video is how the implementation of the robotic surgery is.
Okay. Please go on.
Can everybody see this?
Yes.
Okay, the video is going, everybody can see it. Okay, so this is our intraoperative settings, skin fiduciary for registration accuracy check. We have reference area which is attached to spinous process proximal to the surgical field. We perform an intraoperative CT for automatic registration. We do the registration accuracy check on the skin fiduciaries. We fuse the preoperative and intraoperative imaging. Calibrate the instrument drill or guide holder. And then we go with the robotic arm over the pre-planned entry point of the pre-planned trajectory. And then the robotic arm, you see these very small, delicate movements of the kinematic unit of the robotic arm. The robotic arm moves by itself according to the trajectory. And this is what I see.
Sorry, we can't
say anything. We couldn't say anything.
We can't see the video. You have not, maybe you have not shared the video.
Just a second. I'm sorry, why it doesn't work. I would like to show you that it looks that it's not going to work today. I can try one more time. And wait. Okay. Is this now to be seen?
Yes.
Okay, very good. So this is the first video on use of augmented reality for resection of thoracic herniated disc. This is a preoperative CT which shows a calcified herniated disc. These are the preoperative imaging following placement of retraction. And you see here very nicely, this is the retractor arm, this is cranial, this is caudal. So I'm behind the patient, he's on his right side, right decubital position. These are the outlines of the vertebrae, and this is outline of the herniated disc. And as we go through the surgery, first we do the calibration of the microscope using the reference array. You see the whole time the 3D reconstructions, or this is 2D, but you can also make it in 3D reconstruction of vertebrae. And we do the drilling of the bone in the outline of the herniated disc, in the blue outline. And then every time of the surgery, you actually know where is the disc, you know, where are the vertebrae, where is the intervertebral disc space. And this allows you actually, you can also do the reconstruction of the spinal cord. You can do the reconstruction of the vessels of aorta if you want to do a corpectomy, which is near aorta. And this actually allows you to see to have the anatomy present and not to operate blind. And all you need to do is have a very good preoperative scan and a microscope application or application of augmented reality. This is now dural sec, or this is now the ligamentum flavo. We expose now the spinal cord or the dural sec. And this is the calcified disc, which is then being removed by a Kereson rongeur. And if we just put it a bit, now you see a very nice situation at almost the end of the surgery where you have ventrolaterally exposed spinal cord, and now you have a three-dimensional reconstruction of the vertebrae and of the herniated disc. And you see there where you had the herniated disc, now you don't have one, and you have exposed dural sec, which is then pulsating, does not have any iatrogenic or intraoperative injury. And this patient had also a very good outcome. He had a paraparesis, or he cannot walk, and he does not have any bladder or stool issues. This is the intraoperative CT fused, also shows that the herniated disc, calcified herniated disc, is completely removed.